very good afternoon to everybody. It is indeed a pleasure to invite you all for this inaugural iIGF deficiency program, which is a unique program which we have developed basically, which incorporates each and every aspect of IGF deficiency. A lot of issues in terms of evaluation, in terms of assessment and management, and many of these problems are actually not really catered for in terms of appropriate manner. So what we have done is that over the next 2 hours or so, we'll focus about the various aspects of IGF deficiency, right starting from pathophysiology, which is in itself a complicated issue, to take over in terms of when to think of the conditions, which will be discussed by Dr. Neha. Then we'll take forward with regards to the evaluation, the etiology, going forward in terms of the role of IGF-1 and BP3, which Dr. Sajali will take over. Then we'll have the growth hormone stimulation and dynamic test. Dr. Riddhi will take over. Then subsequently we'll talk about in terms of management, in terms of the conventional GH therapy, the long-acting GH therapy, which Dr. Chetan will be talking about. Subsequent to that, we'll talk about pubertal modulation, the role of GnRH analogs, and the role of aromatase inhibitors, Dr. Pratik, and finally IGF deficiency. So this is going to be overall a compact program of 2.5 hours, in which we'll cover a lot of these things, starting from basic pathophysiology to the different aspects, covering different the whole aspects and gamut of this disorder directly with pathophysiology. And all we know is that the growth hormone releasing hormone is the key regulator of growth hormone secretion. It acts on the pituitary on its receptor to cause production of growth hormone, which is then taken off by the growth hormone binding protein. Now, this growth hormone binding protein is the extracellular domain of the growth hormone receptor, and the levels of growth hormone binding protein therefore provide us information about the growth hormone receptor defects, particularly the classical defect in the form of Lavin syndrome. So if the GHBP levels are low, there is an extracellular domain defect. Now, this is very interesting because hardly any peptide hormones have a binding protein. So what does this GHBP do? This GHBP is basically avoiding the binding of growth hormone to the circulating receptors. So in a way, it is allowing greater amount of growth hormone to be used, and it is directing this growth hormone to its target site of action. So it's very, very important from that clinical perspective. Now, this growth hormone that acts on the growth hormone receptor, there are multiple places where it acts, but the most important site of action is the liver, where it acts to produce 3 growth hormone dependent peptides, and these are the 3 which Sajali will talk about when we talk about evaluation. The most important, of course, is the IGF-1, followed by IGF-BP and acid labile suspect. Now, all 3 of them form a ternary complex, and from there, they will basically move and be taken towards the target site of action, which is basically at the level of the chondrocyte, where the IGF-1 acts on the IGF receptor. So this is the conventional way of the GH-RH-GH-IGF system. A growth hormone is a complex hormone, a large hormone, a single peptide chain with some disulfide bonds which are there. This is basically a non-glycosylated protein with disulfide bonds. The reason we are focusing on this structure is that if you have to create growth hormone, it is not a simple biological process. It's not a simple biochemical process. It's actually a biological process. So process itself becomes important, and therefore, if you have a biosimilar compound which is produced similar to growth hormone, it has to go through the entire evaluation with regards to the overall aspects, with regards to the overall development in terms of the validation of that biosimilar, in terms of its biological activity and safety in that regards. Now, there are other homologs of growth hormone which are there in terms of prolactin, human chorionic somatotropin, and the human growth hormone from the placenta. Now, this growth hormone is produced from the chromosome 17, the gene which is there, the GH1 gene, which is a major regulator of growth hormone production. It is produced as a pre-growth hormone, which is then split into a signal peptide and a growth hormone molecule. Now, this growth hormone molecule then is basically there for release. Now, many of these large molecules, when we talk about growth hormone, we talk about insulin, we talk about AVP and PTH, they are all big molecules. They take time to synthesize. So they are actually stored in the vesicles. So growth hormone is stored in the somatotropes, and from there, it is released under specific findings, and zinc plays an important role in that regards. Now, the overall process of development of somatotrophs is regulated by a number of genes, and this we know is a complicated pathway, but one which we need to really understand importantly. So we've got three basic group of genes which regulate the early embryogenesis in the form of the genes which involve the craniofacial development like HESX1, SOX3, LHX3, and PITX2. These are the ones which are basically involved in early development of the pituitary. Abnormality of these genes will result in a clinical picture which will basically have a combined hypothalamic pituitary defect, visual, ocular, teeth, and as well as a number of other manifestations. The spine defects will be there, and they will have a multiple pituitary hormone deficiency. The second group of genes, the most important of one, is PROP1, is the ones which basically start acting to suppress the proximal gene. So the onset of PROP1 basically means that the HESX1 goes off and the POW1F1 starts to work, and their defects are basically restricted to the pituitary. They do not have an extra pituitary phenotype, and they're mainly present with hormone deficiency. So we have PROP1, which causes the growth hormone, the prolactin, the TSH, the ACTH, and the variable gonadotrophin deficiency. You've got POW1F1, which causes the growth hormone, prolactin, and TSH deficiency, which we'll talk about a bit more when we talk about genetics in that regard. The key regulator of growth hormone production are the growth hormone receptor releasing hormone GHRH receptor, as well as the GH1 gene. Now, what's very important to understand that while we say that there is a GHRH, iGF1 pathway, which is the major regulator of growth, what we need to really understand is that there are multiple independent effects of these molecules. So the GHRH is not just working at the level of producing GH, it is also working in terms of many other effects which are there. Therefore, the manifestation of individuals who have a GHRH receptor mutation will be different from other individuals. So in particular, if you have a GHRH receptor deficiency, the manifestations will not cause micropenis, will not cause hypoglycemia. So absence of micropenis, absence of hypoglycemia, which are considered to be a classical feature of the GHD. If you have a very short child, think of a GHRH deficiency. Similarly, we'll talk about when you have a growth hormone resistance, there will be a higher likelihood of things like sparse hair, like frontal bossing, which are more characteristic of growth hormone insensitivity than growth hormone deficiency. So there are GHRH effects which are independent of GH. There are GH effects which are independent of IGF-1, and that's very important to understand from that perspective. Now, this growth hormone secretion, as we discussed it, their major regulations at the level of secretion. Now, this is regulated by two antagonistic hormones. So we've got the growth hormone releasing hormone, which potentiates the growth hormone releasing hormone receptor, which is basically a G protein coupled receptor. It basically increases growth hormone production as well as secretion. Now we've got somatostatin, which inhibits this growth hormone release. So while GHRH is a continuously active hormone, somatostatin is one which is there in between. So what it is doing is that it is really allowing the pulses to form, and that is the important role. And if you have got high somatostatin, the growth hormone secretion decreases. Once they go low, it again increases. So this pulsatile secretion is related to somatostatin to a certain extent. A very potent growth hormone stimulator is the ghrelin, which is basically secreted by the stomach. When your stomach is empty, you are hungry, it produces ghrelin, which acts by the secretagogue receptor to cause stimulation of growth hormone. This has got two implications. Recently, there are compounds which have been developed, which are basically the secretagogues, which cause increased growth hormone secretion, and they are being used at least for diagnostics of GHD. And they will talk about one molecule which has already been approved in the adults. At the moment, there are studies in children which are going on. Secondly, malnutrition will cause greater ghrelin secretion, and this will cause increased growth hormone. So malnutrition causes increased growth hormone, but body does not have enough energy to grow. So what does it do? So it basically does is that this growth hormone is high, but there is a resistance at the level of liver. So malnutrition is a classic growth hormone resistant state in which the growth hormone levels are high, but the growth hormone effect is less. And this is opposite to obesity, which we'll talk a bit later. Now, this growth hormone release is also influenced by a number of compounds like thyroxine, which is central for growth. It basically controls that. Then we have got the estrogen, which is a major stimulus of secretion of growth hormone. What it means is that in prepubertal individuals, both boys and girls, and as Pratik will talk about, that local aromatase production plays a very, very important role in boys. The growth hormone secretion will be low, and if we do not have a proper pubertal development or a priming, you will find that there will be decreased growth hormone levels, giving a false positive diagnosis of growth hormone deficiency. And this really highlights the importance of doing a sex hormone priming in this setting. Now, this growth hormone is inhibited by cortisol, which is an important mechanism by which it causes decrease in that. So therefore, we need to ensure that the cortisol levels are normal and thyroxine levels are normal before we really go ahead with a growth hormone stimulation test. Otherwise, hypothyroidism will cause a false positive diagnosis of GHD. Hypocortisolism may actually have a false negative diagnosis of GHD. And in fact, certain situations like familial glucocorticoid deficiency type 1, which is because of the MC2 receptor defect, there is decreased cortisol effect causing increased growth. So cortisol deficiency, we always think about Cushing's causing decreased growth. Cortisol deficiency can also cause increased growth in certain situations. Now, of course, we have got the IGF-1, which will suppress the growth hormone production by its own feedback mechanism in that perspective. Now, as discussed, because of this combination of GHRH and somatostatin, we have these pulsatile growth hormone secretion. Maximum pulses happen around stage 2 to 3 of the sleep, and this is when we need to be really cautious in terms of having sleep disorders affecting growth, and this becomes important from a clinical perspective in that regards. Now, fasting is also important. If you're fasting, your growth hormone will grow. If you're not fasting, your growth hormone levels may be variable because of the ghrelin effect. So therefore, if you want to diagnose somebody's growth hormone deficiency, the ideal time to do a growth hormone stimulation test is in the morning in a fasting state in that situation. And very importantly, it may be affected by a number of other factors. So this understanding of the single slide really gives you a lot of information about pathophysiology of this entire growth hormone axis in that regard. Now, growth hormone basically acts to the type 1 cytokine receptor. It activates and binds to the extracellular domain, causing the approximation of these, resulting in an opening of the intracellular domain, wherein there is cross-linking, and this activates the JAK pathway, which stimulates STAT5. STAT5B is the major mediator of growth hormone effect. It basically goes to the nucleus, stimulates the STAT response elements, producing IGF-1, BP3, and ALS. So GH is ultimately causing the genomic effect, and that's why the effect is slow. There is a membrane effect, of course, but that's ultimately mediated by the STAT pathway. Defects in the extracellular domain, in the intracellular domain, in the JAK, in the STAT, in the SRA, in the IGF gene, or in the IGF-1 receptor will all result in what we can call, quote unquote, IGF deficiency or impaired IGF effect, for a very precise word in that regard. Now, the growth hormone levels depend upon the stage of life. They are very low in the fetal period because the fetal growth is independent of GH. They suddenly rise after birth. That is basically because of lack of inhibitory compounds, and they then rise, and after that they trigger again in puberty. So the requirement of growth hormone will vary depending upon different ages. So physiological production will be around 25 micrograms per kg per day in childhood. It basically peaks around puberty to around 35 to 45. And this has resulted in certain recommendations that we should actually increase the secretion of growth hormone in that perspective, give the dose on the higher side, but that has not been proven to be effective in this situation. So we do not recommend a routine increase in the dose of growth hormone in this setting. As age grows, growth hormone's role on growth becomes less, but it is very important for around 25 years of age on bone, and that is why we talk about giving treatment for bone around 25 micrograms per kg per day, and then the effect is mainly at the level of adipocytes, which Neha will talk about, and this is mainly from adult perspective, and then finally we have a somatopause after which the dose becomes less. Now, the IGF-1 system is basically growth hormone dependent. Growth hormone acts on the growth hormone receptor to produce IGF-1 and IGF-BP3 and acyl-levine substrate. The IGF-1 acts on the type 1 IGF receptor. Now, this is the major mediator of growth. It causes cellular growth, prevention of apoptosis, and differentiation. So this basically causes increased growth. IGF-2 is also produced locally, but this is not growth hormone dependent. It has got minimal effect on the type 1 IGF receptor. We also have a similar compound. So insulin basically has got a homology to IGF-1, and insulin acts on the insulin receptor to cause growth as well as glycogenolysis, inhibition of ketogenesis, and anabolism. Now, there is a structural similarity. So IGF-1 has got 5% effect on the insulin receptor, and therefore IGF-1 use will cause hypoglycemia. And this is something you have to be very careful about. And this we will talk about as to why we need to have a snack of carbohydrate before giving IGF-1 in that situation. Now, IGF-2 is mainly acting on the type 2 IGF receptor, wherein it causes growth inhibition. So this is a yin-yang phenomena. It increases at one side, decreases on the other. Other compounds like IGF-1 do not influence the type 2 receptor. Insulin, on the other hand, also acts on the type 1 IGF receptor, and therefore hyperinsulinism because of whatever reason in the form of potassium ATP defect, in form of infant or diabetic mother, causes macrosomia. This insulin, of course, doesn't have an effect on the type 2 IGF receptor. So the effect of IGF-1, 2, and insulin depends upon how much they act on a particular type of receptor in that regard. Now, IGF-1 basically acts through the receptor which has got a alpha and beta chain, which is an inherent intrinsic tyrosine kinase receptor, stimulating the most important growth pathway, the MAP kinase and the PI3 kinase. Now, what we need to understand is that while growth hormone is predominantly acting through IGF-1, it also has got a IGF-1 independent effect. So IGF-1 will act on the IGF-1 receptor on the growth plate to cause increased growth. Growth hormone also have other IGF-1 independent effects. It has a direct effect on the lipids causing lipolysis, causing free fatty acid generation. It acts on the kidneys to cause phosphorus absorption. It acts on the bone to cause skeletal growth. It also has got a very important effect on the hepatic glucose metabolism to cause hyperglycemia. So growth hormone treatment will increase glucose, while IGF-1 will cause decreased glucose. This is a big dichotomy that we see in terms of therapy. Now, the other thing is that growth hormone also acts on the chondrocyte growth hormone receptor to increase IGF-1. So basically, it's not just the systemic IGF-1 produced by growth hormone, it's also the growth hormone which is being produced at the IGF-1 which is being produced at the level of the chondrocyte, which plays an important role in that regard, and that's pretty important from that perspective. So just to summarize from a very chondrocyte-specific pathway, what we're looking at is that growth hormone is stimulating IGF-1 production in the liver, which is causing growth, but it is also causing multiple effects. So IGF-1 causes increased proliferation of the cells. It causes decreased apoptosis. So net thing is increased growth of the growth plate. Now, this growth hormone also acts on growth hormone receptor in the bone to produce IGF-1, and which has a paracrine effect. So when you're giving growth hormone, you've got an endocrine effect as well, and you've got a paracrine effect as well. So this becomes very, very important in that treatment with growth hormone will be more effective as compared to treatment with IGF-1, because you've got both paracrine, endocrine, and a direct GH effect. The other major difference is that with growth hormone treatment, your IGF-1 will increase, but IGF-BP will also increase. So the amount of free IGF-1 which is being produced will be less, and free IGF-1 is a risk factor for malignancy. So growth hormone therapy has a lower risk theoretically of malignancy as compared to IGF-1, and this is a very important aspect when you want to compare in terms of IGF-1 therapy, and this is what we will talk about in that regard. Now, growth hormone also has a direct effect on the bone morphogenic protein, causing an effect in terms of the resting chondrocytes as well. So in a way, there are four parts of growth hormone effects, I would say. Production of IGF-1, which is systemic, local IGF-1 production, direct effect on the growth hormone receptor, and increasing IGF-BP. And that's why if you have a child in which growth hormone is also working and IGF-1 is also working, you don't have to think about anything, give growth hormone. In fact, the latest recommendations do say that even in IGF-1 deficiency, unless you have a genetically proven cause, you give growth hormone trial and there is no response, then you start worrying and thinking of IGF-1 in that regard. So this is very important. Just to summarize now the entire excess. So what we're looking at is that somatostatin and cortisol are inhibiting growth hormone secretion, causing decreased growth. Thyroxine is stimulating, and there is a direct link between the adipocyte and the growth hormone secretion. Ghrelin is basically increasing growth hormone, while in obesity what is happening is that insulin is going to decrease IGF-BP, increasing free IGF-1. So basically, overnutrition, your growth hormone is low, but your IGF-1 is high. So this is a growth hormone sensitive state. And in adults, lower cutoffs have been recommended for obese individuals for GHD. This is not yet true for children, but this is an important to consider, that you may actually falsely label an obese child as GHD because of this insulin effect. Now, we also know that if you have undernutrition, as discussed, the GH is high, but growth hormone responsiveness is less. So undernutrition is a growth hormone resistant state in that regard. Very importantly, estrogen is also being produced, is an important regulator of growth hormone, and this is important from a priming perspective. Estrogen also has an effect on the hepatic growth hormone action. So if somebody is on an oral estrogen, you will have a suppression of IGF-1 production, and this will cause a lot of problems. So it is always preferable to use a transdermal estrogen, which really bypasses the liver. Otherwise, your IGF-1 level will go down. And estrogen also has an effect in terms of epiphyseal fusion, which is the final mediator in that regard. So oral estrogen decreases the IGF-1, while transdermal does not, and this is very important in that regard. And the role of estrogen is highlighted by this 13-year-old boy with growth failure. What we see is that this child was short, mid-parental height was normal, bone age was slightly delayed, he was prepubertal, and he was found to have low growth hormone and growth hormone stimulation test. Now, if you look at this chart, just memorize this. 99% of these individuals have constitutional delay of puberty and growth. Just below the growth chart, the bone age, which is the yellow dot, is within the normal range. So this you do not need to do a growth hormone stimulation test. If you do a primed test, and if he had given testosterone, his growth hormone response would have been normal in that situation. So this is a very important aspect to consider.